Welcome to QD Clinic. I'm Jack Cush with Room Now. QD Clinic, interesting cases for big thinkers like you. QD Clinic is brought to you by Room Now's coverage of ACR 21. Smart thinkers spend their time smartly with Room Now during the next week. It starts on Friday the 5th. But today we're going to talk about lupus. And lupus is a challenge for some. But what do you do with the patient who has clinically inactive disease, but serologically active disease? You've heard me say before, don't treat a lab. You said it yourself. I don't treat labs. But this is kind of a scary situation, is it not? And what do you do, and what does the literature say? We have a report on Room Now this week coming from a cohort in China that looked at their population, and I think it's somewhat telltale. Interestingly, this topic of serologically active, clinically quiescent disease has got a fair amount of literature. It's mostly dominated by this group and this report I'm going to tell you about, and Daphne Gladman's group in Toronto, Steinman, Gladman, Murray Urowitz in Toronto. They've studied this and written the most about it, and there's a few others who comment on this. There's almost agreement in the thinking. So here's the story. And you've seen the patient. You know, they're doing well, but they have serologic activity. No rash, no arthritis, no proteinuria, no cytopenias, but their double-stranded DNA is high. You know, higher than you like to see. The C3, which was once normal, is now low. Could be the C4. So the question is, what do you do with this? Well, in this Chinese cohort, 282 lupus patients, about 25% of their population they called clinically quiescent. Let's start over. Serologically active, but clinically quiescent. About another 27% were serologically quiescent, clinically quiescent, so truly quiet patients. And they compared those two. They were about the same age. Otherwise they matched up well, but the flare rates were different. So the flare rate in the patients who were serologically quiescent, clinically quiescent, all good, they had a 15% flare rate in the next 6 months. Whereas those that were serologically active but clinically quiescent, their flare rate was 33%, more than double the rate. So they came down on the side of saying such patients need to probably be on therapy. In fact, when you looked at those patients, predictive factors for flare were those that were on steroids, and you couldn't get into the study if you had steroids of more than 7.5 milligrams a day. But then maybe steroids were telling you something, right? Patients who are more likely to, in fact, have active disease. And the protective factors were antimalarials and other immunosuppressors. Interestingly, the antimalarials, the odd ratio was 0.045. That's like 99% protective. Whereas being on other immunosuppressants, azathioprine, mycophenolate, was about 67% protective. So, obviously we're not talking about patients here who are serologically active, clinically quiescent, but have no treatment. And this data says that being on some treatment may help you to avert future flares. This is not an uncommon problem. The literature says somewhere between 2 and 12% of patients with lupus will be in this category of serologically active, clinically quiescent disease. But there's not necessarily an agreement about whether you just watch with vigilance or whether you should be treating. There's one study that says you should give a short course of medium dose steroids to avert that. But if you keep doing that, every time you get itchy because of a lab, you're going to over-steroid the patient. That's not nice. The outcomes are bad. Then again, you should monitor. And, I don't know about you, but my lupus patients, I generally like to see every 3 months. Maybe someone like this, maybe every 2 months, maybe more. And I think that the last 6 months is probably going to predict the next 6 months. And not always the case, but the longer you follow them, the more comfortable you can be with this particular scenario. Interestingly, monitoring acute phase reactants or cell counts or double-stranded DNA, etc., it may be helpful, but none is truly predictive. My advice is don't treat the lab, but worry a whole lot. I'd like to know what you think. Tune in for more QD clinics. And, Room Now, we're going to do an interesting thing. At the end of every day during ACR, starting on Friday, Saturday, Sunday, Monday, Tuesday, we're going to have a daily recap. I'll get together with some of the Room Now faculty and talk about the highlights of the day. This is what you should be doing if you're trying to find a nice way to learn the meeting. You should invest your time, watch the abstracts, look at the presentations as they happen, do your pre-work, get your agenda set, and then meet up with some colleagues and friends over pizza and beer or at your academic center and discuss this. If you don't want to do it, we'll do it for you. Look for our daily recaps on Room Now. Tune in tomorrow.